Okay, let's unpack this. We often dedicate our deep dives to, mysteries, future tech, or complex global politics. But today, we are talking about a scientific victory. I mean, a breakthrough so complete that global health bodies are now confidently planning to eliminate a major human cancer within our lifetimes.
That's the stunning reality, yeah. We're discussing a transformation of public health that moves cancer prevention from, uh, from a hopeful concept to an active, scalable global mission. This is all about foundational molecular work, amazing clinical trials, and radical policy shifts happening right now.
And the impetus for this deep dive and our source material today is the 2025 VinFuture Grand Prize. For those of you who aren't familiar, this is one of the world's most prestigious science and tech awards valued at a cool 3 million US dollars. It recognized 4 incredible scientists who collaboratively cracked the code on preventing human papillomavirus or HPV-associated cancers.
Right, we're looking at the decades-long combined effort of Dr. Douglas R. Lowy and Dr. John T. Schiller from the National Cancer Institute, and Dr. Aimée R. Kreimer and Professor Maura L. Gillison from MD Anderson Cancer Center.
Their roles are so distinct but absolutely essential. Lowy and Schiller, they laid the groundwork with the molecular invention itself. Then Kreimer solved the huge challenge of global delivery and logistics. And Gillison, she fundamentally redefined the scope of the disease, making sure this vaccine protects way more people against more cancers than we even realized at first.
And our mission today is pretty simple. We want to understand how this collaborative research moved HPV from being a complex, silent public health threat. I mean, it's responsible for over 920,000 cancer cases worldwide every year, to a target that organizations like the WHO believe we can genuinely eliminate. It's just an absolute masterclass in translational science.
It truly is. So let's start where it all began, the molecular magic that lets us vaccinate against a virus without ever actually, injecting a piece of infectious material. How do you create a perfect shield?
That takes us straight to the initial breakthrough by Drs. Lowy and Schiller, the creation of something called virus-like particles, or VLPs. So think of a virus, like HPV, as a functional spaceship, like the Millennium Falcon. It's got the outer hull, but crucially, it has the hyperdrive, the crew, the weapon systems inside. That's the infectious DNA.
So the VLP is just the outer hull.
Exactly. It's the outer hull sitting safely in a museum. It looks exactly like the threat to your immune system, but it's non-infectious. It completely lacks the vital genomic DNA, so it just can't cause disease. Our sources describe them as morphologically and antigenically indistinguishable from native virions. In plain English, your body sees the perfect decoy.
And the immune system falls for it, hook, line, and sinker.
It does. Their discovery began with systematic work on the bovine papillomavirus, PPV. They realized that the L1 major capsid protein of the papillomavirus has this remarkable innate ability to spontaneously self-assemble into this spherical shell. No fancy factory needed.
That sounds incredibly elegant, like nature just providing the perfect solution, but I know science never runs that smoothly. Where was the snag in this seemingly easy self-assembly process?
That's where the narrative struggle comes in, and it's a great wow moment. For a long time, researchers using the common reference strain of HPV-16 just kept hitting a wall. The L1 proteins wouldn't assemble correctly in the lab, and they eventually realized the strain they were using, which had been passed down in lab cultures for decades, it harbored a subtle mutation.
Wait. So they were essentially testing on a sick or a broken version of the virus, and the results were all skewed.
Precisely. It was a subtle but, a massive scientific stumbling block. The fix, which was brilliant, came when they isolated the wild-type HPV-16 L1 capsid protein, but not from the commonly used cancer-derived lab strains. They got it from benign cervical infections.
So they went back to the source, the virus doing its job naturally, not the one that had been mutated and adapted in a lab dish.
That's right. And by switching the source material, they confirmed this robust self-assembly process. They found around 360 copies of the L1 protein come together, and they rely on these specific molecular connections, disulfide linkages formed by these amino acid residues, cis-175 and cis-428. What's amazing is that this complex, perfect assembly, it just happens spontaneously. No helper or chaperone proteins. It's a purely natural phenomenon that they harnessed for the vaccine.
So why is this perfect decoy so much better at triggering an immune response than a natural HPV infection? You hear about people getting infections all the time. Shouldn't that provide some immunity?
Well, a natural infection, it generates some antibodies, sure, but it's often very stealthy and superficial. The VLP, by contrast, is a large, highly structured particle, a big 60-nanometer sphere. Yeah. That structure means it is densely packed with what are called neutralizing epitopes, which are the specific targets your immune system's antibodies need to see.
It's like the virus is running cloaked, but the VLP is holding up a giant neon sign.
Exactly. That high density and particulate structure make the VLP exceptionally potent. It efficiently interacts with antigen-presenting dendritic cells. Those are the immune system's alarm bells, and that leads to a powerhouse response. As a result, the neutralizing antibody titers, that's just the sheer volume of protective antibodies in your blood, induced by the vaccine, they significantly exceed what you get after a natural infection.
That foundational science, the VLP, is clearly revolutionary. But a perfect shield that stays in the lab doesn't help anyone. Here's where it gets really interesting. The biggest challenge wasn't the what, but the how. How do you deploy this globally, especially in resource-limited settings?
And that brings us to part two, solving the logistics problem. We have to remember that 85% of cervical cancer cases and 90% of deaths occur in low and middle-income countries. And previously, the standard protocol was a multi-dose schedule, requiring 2 or 3 injections spread out over months.
Right. And as we know from any public health initiative, getting people, especially adolescents, to come back for dose 2 and dose 3 is one of the most significant and stubborn logistical hurdles on the planet.
Absolutely. Just think about the complexity. The need for cold storage, repeated patient tracking, coordinating clinic visits, ensuring consistent compliance. It's a system that's almost designed to fail in remote or high turnover populations.
This is where Dr. Aimée R. Kreimer's work changed the game, specifically through the landmark Phase 3 clinical trial, the Costa Rica HPV vaccine trial, or CVT. And the sources note that the key observation was initially almost accidental.
It was a beautiful moment of scientific serendipity. In the initial study cohort, about 20% of participants, they involuntarily received fewer than the 3 planned doses, due to things like moving away or becoming pregnant. When Dr. Kreimer's team conducted a post-hoc analysis on those individuals, they noticed something remarkable. The efficacy seemed just as high with the reduced doses.
So the data were just screaming at them, hey, look over here, this might be simpler than you think.
That signal was strong enough to launch the definitive large-scale randomized controlled trial, which was published in the New England Journal of Medicine in December 2025. This was a massive undertaking. They enrolled over 20,000 girls, aged 12 to 16, in Costa Rica, and they compared a 1-dose regimen directly against the traditional 2-dose schedule.
And what did this prospective 5-year surveillance trial confirm for our listener?
It confirmed the revolution. The single-dose vaccination showed approximately 97% protection against persistent HPV-16 and HPV-18 infections over 5 years. And critically, the efficacy between 1 and 2 doses showed minimal differences.
So if the effect is equivalent, and statistically it's not worse, that means the 1-dose protocol is deemed non-inferior.
Precisely. Non-inferiority means we can treat the 1-dose result with the same confidence we held for the multi-dose regimen. The protection wasn't just high, it was durable. The single-dose recipients maintained robust HPV-16 seropositivity rates of 99.8%. Their protective antibody titers stayed 2 to 4 times higher than those from a natural infection, and they persisted robustly throughout the whole 5-year follow-up.
This is the global game changer. It's the logistical shortcut that matters most. When you can send a single team once to a remote village, administer 1 shot, and walk away knowing you've delivered 97% protection for at least 5 years, you have removed the single largest barrier to cancer elimination.
And that's exactly why the World Health Organization now recommends single-dose vaccination as an alternative schedule for individuals aged 9 to 20 years. That policy change alone accelerates the timeline for elimination by decades.
Okay, now let's talk about expanding the scope, because HPV isn't just a disease of the cervix. Let's move to the head and neck, where Professor Maura L. Gillison provided a vital link.
This is crucial, because while cervical cancer is tragically responsible for much of the HPV burden, it only accounts for about 44% of total HPV-associated cancer cases worldwide. If we truly want to eliminate this category of disease, we have to address the rest.
And Professor Gillison focused on the connection between HPV-16 and head and neck squamous cell carcinomas, specifically those affecting the oropharynx, so the tonsil and the base of the tongue.
Her landmark 2000 case control study was the molecular proof. She found HPV-16 DNA in a staggering 72% of oropharyngeal tumor specimens. So she established HPV-positive HNSCC as a distinct disease entity, not just another head and neck cancer, but specifically an HPV cancer.
That simple distinction. So not lumping it in with other smoking and alcohol-related head and neck cancers, but identifying it as a separate viral-driven disease. That must have radically changed how doctors approach treatment.
It did because the epidemiology shifted dramatically right alongside the discovery. Here is the big surprise. In many developed nations, the incidence of HPV-associated oropharyngeal cancer has actually surpassed the incidence of cervical cancer.
And this increase is especially noticeable among men who, traditionally weren't included in the public health narrative around HPV.
Exactly. The HPV DNA prevalence in these specific tumors skyrocketed, moving from just 20.9% before 1990 to 65.4% after 2000. It became the dominant form of the disease.
So we have an exploding incidence rate, which sounds like just unadulterated bad news. But you mentioned there's a vital silver lining tied directly to this viral origin.
Yes, and this is the life-changing part for patients. Gillison's work revealed that HPV-positive tumors have a markedly improved prognosis compared to HPV-negative tumors. The virus status is the single most important predictor of outcome.
How significant is that difference in survival?
Profoundly significant. Patients with the HPV-positive type demonstrate a 59% reduction in the risk of death from cancer. To put numbers on it, the 2-year overall survival rate for HPV-positive patients is 87.9%, compared to just 65.8% for HPV-negative patients.
That is a 22-point swing in overall survival just based on the type of cancer you have. That is astonishing predictive power.
And this is why her work immediately catalyzed a change in standard care. The National Cancer Institute now requires that all head and neck cancer clinical trials stratify patients by HPV status. This move allows for what we call de-escalation trials.
Which means we can use the good prognosis as an excuse to back off the harsh treatments, right?
Precisely. The goal is to reduce treatment intensity, lowering the doses of chemotherapy and radiation, to maintain the high efficacy but drastically lower long-term treatment-related morbidity. For HNSCC, those side effects can be devastating. Chronic dry mouth, difficulty swallowing, speech problems. Gillison's work has led to trials that achieve complete responses while reducing chemo by 40% and radiation by 14%. It transforms the quality of life after cure.
So when you combine the molecular shield, the logistical simplicity, and the expanded protection, you see why this is such a global success story. Let's look at the scope of elimination that this combined work enables.
The population-level data is already jaw-dropping. In the U.S., vaccination programs have led to an 80% reduction in precancerous cervical lesions in young women. In Scotland, they reported 0 cervical cancer diagnoses among vaccinated women born in a specific cohort between 1988 and 1996.
0. That number should be shouted from the rooftops.
And Australia, which has embraced this strategy, projects the elimination of cervical cancer as a public health issue entirely by 2040. When you put this in economic terms, the cost savings are just astronomical.
The data on cost avoidance is staggering. Even back in 2010, the annual direct medical cost in the U.S. for preventing and treating HPV-associated diseases was estimated at $8.0 billion. And that's before you count the productivity loss from cancer deaths, which totaled $4.2 billion in 2017 alone. This isn't just healthcare. This is a profound drain on national economies that is now being reversed.
But we also have to recognize the human toll that goes beyond the statistics of malignancy and money. The unquantifiable burden caused by the non-fatal yet severely impactful manifestations of HPV.
The primary example being genital warts, caused by the low-risk types 6 and 11. They might not be deadly, but the quality of life impact is huge.
It is. They have extremely high recurrence rates, with most recurring within 3 months of initial treatment. This leads to years of clinical visits, painful procedures, and constant monitoring. But the psychosocial impact is arguably worse.
And our sources highlight that the psychosocial effect is amplified because of the stigma attached to an STI diagnosis.
Precisely. Patients report elevated anxiety, depression, shame, and embarrassment. Research indicates this diagnosis causes significant quality of life impairment, often exceeding the psychological burden associated with the much scarier cancer-related HPV diagnoses because of that visibility and stigma.
And finally, we can't forget recurrent respiratory papillomatosis, or RRP. This is a rare, severe condition where tumors grow in the larynx and throat, typically in children, caused by vertical transmission from the mother during birth.
RRP is cruel. It's not curable. It requires repeated, non-stop surgical debridement, cutting the tumors off the vocal cords or airway multiple times a year, often throughout childhood. It causes chronic hoarseness, potential airway obstruction, and incredible distress for the child and the family. Every dose of the HPV vaccine given to a young adult is a defense against RRP for the next generation.
So this combined research effort, recognized by the VinFuture Grand Prize, has addressed the entire spectrum, from the cellular mechanism of infection all the way to the psychological and economic burdens of the disease.
And that's why this story is so compelling.
So what does this all mean?
It means we've witnessed a perfect chain of discovery. Key takeaway number one. The foundational VLP discovery by Lowy and Schiller provided a non-infectious, highly potent molecular decoy that generates an immune response far superior to a natural infection.
Key takeaway number two. Dr. Kreimer's work confirms that a single dose offers robust, durable protection. That removes the biggest logistical barrier to global cancer elimination efforts. The modeling on this alone suggests this policy change could prevent 74 million new cervical cancer cases and 62 million deaths by the year 2120. That is just unprecedented public health leverage.
And key takeaway number three. Professor Gillison's research was crucial in broadening the vaccine's relevance, showing HPV is a major driver of oropharyngeal cancer, particularly among men, while simultaneously guiding treatment teams toward less invasive protocols that drastically improve patient quality of life.
The big picture takeaway here is the incredible return on investment of foundational, curiosity-driven research. The sustained backing of programs like the NIH Intramural Research Program allowed Lowy and Schiller to pursue fundamental virology concepts which, 30 years later, have resulted in a roadmap for global cancer elimination. It shows us what is possible when we stay committed to basic science.
The elimination of cervical cancer is now not a dream, but an achievable target.
We know the single-dose efficacy holds strong for 5 years in preventing cervical cancer. But as researchers look to the next horizon, what remaining question do you think is the most critical for them to answer right now? Is it the long-term durability of that single dose beyond 5 to 10 years? Or is it confirming that the single dose protects just as robustly against the other major HPV-associated cancers, anal, penile, and head and neck cancers? Think about that balance of durability versus broader spectrum protection, especially for the male population.
That is the ultimate public health trade-off, and one that will shape the next decade of research. We'll see you on the next deep dive.